Actually, atrial fibrillation remains a pain in the neck for heart failure patients, and most of the time, heart failure patients do present with aggravation of their symptoms with arrhythmia, and that is what we are dealing right now, atrial fibrillation. Atrial fibrillation has been identified more and more frequently because of some demographic issues of obesity, aging population. And we all are now tuned to get more Holter monitoring, more of the loop recorders. So we are picking up atrial fibrillation more frequently than the previous one. And you can identify that as the NYHA functional class increases, usually the incidence of atrial fibrillation is so prevalent. Sometimes NYHA class 4 patients, 50% of them in acute in-hospital stay will have acute fibrillation. And that atrial fibrillation needs to be addressed very diligently, specifically when the patient is having a preserved systolic function. These patients do have very frequent incidence of atrial fibrillation. And we are really puzzled whether the atrial fibrillation is a cause for heart failure or atrial fibrillation is a consequence of heart failure. We all know pathophysiologic mechanisms, and I may not be going into details. Myocardial fibrosis, mitral regurgitation, increase in the failing pressures associated with heart failure, and that can lead to extra role of atria being called for, and then atrial fibrillation sets in. And when the atrial fibrillation sets in, again the atrial kick is losing the cardiac output and the heart failure propagates. So this is a vicious cycle. We have to break this vicious cycle sometime, and that's where we need to identify how the chamber remodeling has to be given. There are puzzles regarding rate control and rhythm control. Most of us are tuned to rate control, but rhythm control is also a very important aspect. And first of all, I will deal with the rhythm control. Tachycardiomyopathy, and there are few heart failures where restrictive physiologies are there. These two are very important indications for cardioversion, and we need a rhythm control. When you are dealing with heart failure with reduced ejection fraction, of course everybody will go for guideline directed therapy, lifestyle modification, risk factor modification, of course oral anticoagulation, and most of us are doing rate control also. But then there has to be a try for catheter ablation for atrial fibrillation. There are few patients who are amenable to that. That is NYHA class 1 or 2. And those patients who are having tachycardiomyopathy, not much of the ventricular scar on MRI, and minimal fibrosis in atria. But there are few patients who are less likely to be benefited by catheter ablation. And those are NYHA class 3, 4, profound structural scarring is seen, advanced heart failure with severe LV dysfunction, and of course the long-standing atrial fibrillation is less amenable to catheter ablation therapy. Of course, there are charts available. If ablation is successful, then also you have to supervise. It can recur anytime. If your catheter ablation has failed, then you can either try repeat ablation or try rate control. So most of the time we are ending with the rate control in atrial fibrillation. That is the real world scenario. There are trials regarding rate control and rhythm control. AFFIRM has shown no benefit of rhythm control. RACE has shown no benefit of rhythm control. Hot cafe rhythm and rate are equivalent. And very important, very large trial AFCHF that showed that rate control is even better than rhythm control. So we will be going into the rate control aspect. We all have been using beta blockers, calcium channel blockers, and digoxin for rate control. Here there are word of caution for digoxin that if existing ischemia is there, I would love to get one fresh troponin levels, and ischemia is there, I would use rapid digitalization. Otherwise, in acute heart failure with high ventricular rate of atrial fibrillation, Uh, there have been incidences where our teachers used to give rapid digitalization oral or rapid digitalization IV. But that has to be in absence of ischemia. And of course, electrolyte disturbances should not be there, otherwise we will end up in trouble. Similarly, calcium channel blockers, diltiazem and verapamil, they have been used non-dehydropyridine derivatives, but these calcium channel blockers also have a negative inotropy. So rate control has to be very diligently tackled. I think most of us are using amiodarone for rate control, amiodarone oral or amiodarone IV, but that will tackle later on. When it comes to rhythm control, again, amiodarone, sotalol, dopteridine, these are the cornerstones of therapy. We have been using amiodarone IV for rate control as well as rhythm control, and dopteridine has already been identified. Of course, if you are using a very perfect guideline-mediated heart failure therapy, then new onset atrial fibrillation is less likely to happen. That means that if you have used judiciously used ACE inhibitor ARB, then new onset atrial fibrillation will be much less. Similarly, if you have used aldosterone antagonist very perfectly, then the new onset atrial fibrillation is less frequent scenario in heart failure settings. So we prevent atrial fibrillation in heart failure by proper guideline mediated therapy. There are steps involved in these things. We have already established and discussed about these things, but go to the last downward panel where it has been identified that catheter ablation is first line 2A recommendation, and amiodarone has been a medical therapy 1A recommendation. There are some precipitating factors in heart failure. We are dealing with in-hospital journey, and in-hospital journey of heart failure, these are the culprits of atrial fibrillation fast VR. And I would just draw your attention of hypoxia and pulmonary embolism. If a patient has respiratory tract infection and hypoxia, if a patient has pulmonary embolism, they are likely to develop atrial fibrillation. And unless we treat those precipitating factors, namely hypoxia, sepsis, hypokalemia, hypomagnesemia, atrial ischemia, ACS patients do have atrial ischemia also, hyperthyroidism, anemia, sometimes Takotsubo in emergency settings, they can also precipitate atrial fibrillation. We have two options. Amiodarone, almost everybody know. I may not go into details. Ibutyllide IV, a drug which has been identified for cardioversion, rapid cardioversion by IV therapy. It may be used for recent onset atrial fibrillation or flutter, or sometimes persistent atrial fibrillation as a standalone therapy, or in association with oral amiodarone. It is safe to use. If a patient is already on oral amiodarone, it is safe to use. Or it may facilitate electrical cardioversion. I will just go one by one all these indications. And post-operative patients, many cardiac surgeons say that atrial fibrillations are very common in post-operative phase, and ibutyllide can revert it back to the sinus rhythm. It's a class 3 antiarrhythmic, but at the same time using some different sodium channel inhibition, and ibutyllide has a very significant impact. Most of the antiarrhythmic drugs do have a negative inotropic action. They have reduction in cardiac output, but at the same time I would just draw your attention that cardiac output is not much affected. Dosage is a matter of discussion later on, but I would just draw your attention that it should not be used more than 2 infusions. It should not be used when QTC is more than 440 milliseconds. Can be used in successfully for atrial flutter rhythm as well as recent onset arrhythmia. Here I would draw your attention that there are 2 molecules which are concomitantly used. One is amiodarone and second is esmolol. It is safe to use in oral amiodarone loaded patients, as well as if you use IV beta-lock or IV esmolol, probably ibutyllide therapy will give you an excellent result later on. Cardioversion, recent onset cardioversion, I have all these data, but just for the sake of time, I would just draw your attention that ibutolide has a class 1 indication for atrial flutter fibrillation, WPW and pre-excitation flutter, or postoperative cardiac class 2A indication. I would just immediately jump into, because I am not going into details, but the reversal rate is somewhere around 70%. The first line, amiodarone as well as ibutolide, both can revert to 70%. And the time taken, you know, everybody has experience amiodarone takes 5, 6, 7 hours of reversal of sinus rhythm, while ibutolide has few minutes only. So that's the benefit of ibutolide. Reversal bar graph and pie graph are always favoring use of ibutolide in acute atrial fibrillation, and second dose sometimes is needed. Probably second dose is likely to benefit more. If you are planning a electrical cardioversion, then again it will be very beneficial. I would draw one more concomitant therapy. Amiodarone we have discussed beta blocker. We can use magnesium as a concomitant therapy for ibutolide therapy. So cardioversion approximately comes to 70%. Rapid termination should be given with the concomitant supportive therapy, which I have already narrated. Of course, oral anticoagulants remain a main cornerstay of atrial fibrillation therapy in heart failure, but choice of molecule, the dosage, the combination, and duration. So many questions related to anticoagulation therapy in atrial fibrillation. It's beyond the scope of my 10 minutes tenure. And that is why we all agree that oral anticoagulants has to be given, or IV heparin has to be given when you are planning a cardioversion. And thank you very much for my listening to my talk.